Hello, I am Stacy Murphy, and I'm glad to be here with y'all today. I wanted to go over a presentation for what it is to be a pelvic floor physical therapist. How did I get here? What does it take to do that? And what kind of clients do you end up treating and being with and spending all your days? And so I hope that this is interesting because this is not what I thought I was going to be doing 15 years ago whenever I was in PT school. So I'm going to share my screen with y'all, and here is the presentation. So again, I am Stacy Murphy. I went to Texas State for undergraduate and got my doctorate at Texas State as well. Then in 2022, so 11 years after being a PT, I got my PRPC, which is the Pelvic Rehab Practitioner Certification. It actually takes thousands of hours and multiple years to earn that certification. It's a really long test. It was almost as long and complicated and scary as getting your physical therapy license. I had already started doing pelvic floor physical therapy in 2013 and then started back up again in 2019. And so then it took me that many years, 3 years, to earn that PRPC. Then in 2024, I got my pregnancy and postpartum corrective exercise specialist certification. And so um, that was fun because I wanted to see like what other things can I be better at, and it's definitely a pregnancy and postpartum world because there's so much you can't do because they can't lay on their tummies, and so I wanted to expand my knowledge on that. Things that I'm still interested in is scoliosis. I also um, do have my LSVT certification, which is Parkinson's. So LSVT stands for Lee Sylvan Voice Treatment, and actually I got that straight out of school. I love Parkinson's. I love that exercise is the prescription that people can keep their symptoms at bay by just moving, which is lovely. And then I still am on a journey to specialize in fertility. So I already treat a ton of fertility. I just don't have the letters at the end of my name because it is sad whenever someone suffers from loss. And so it's just something that I need to stick my neck out there and tell everyone I treat. But I've walked through so many losses, not because of physical therapy, just so many losses that it's painful. And so I work for physical therapy of Wimberley and physical therapy of San Marcos. They are sister locations, and I specialize in physical therapy for men and women. So, why did I end up with pelvic floor physical therapy? So, when I got to Texas State, I needed to get a job, and I found out that they were hiring at CTMC here in town and that they paid $10 an hour, which in 2008 was a ton of money. Actually, in 2004 was whenever I started. And so I worked weekends there, and it was really nice because I got all these hours to get into PT school, and then I got paid for them. And as a tech in an acute setting, I don't know if y'all have ever shadowed in an acute setting, but if you're the low man on the totem pole, then you're the one that's usually wiping the bottom. So in acute care, the physical therapists are the ones that help people get out of bed, and the best way to get people moving and out of the hospital is to help them walk, so that way they will poop. And so I just started getting really comfortable talking about that. I vowed that I would never get back into acute setting after doing that for 7 years. And then whenever I graduated, I actually started outpatient. And so it was nice because I got to use all of this bedside manner. You have to be very kind and very make sure that they have their water they can reach and their little remote control, for their bed and the nurse's light all within reach. And then I got to apply that to an outpatient setting and just be very much a servant, which is lovely. But in PT school, the day before we graduate, they start to introduce us to pelvic floor. And a lady came in and she had a biofeedback machine. She had 10 of them. There's four different electrodes to that thing. And she's told all of us to put these little sensors, teeny tiny sensors, at our bottom at 3 and 9 o'clock of our rectum and pull our pants back up and have a little tail coming out of our pants and then come back in and we were going to talk about pelvic floor. And I thought that she was so weird. I was like, I am never doing this. But then, as we're wearing those electrodes and watching what our pelvic floor is doing on this screen, it was interesting because one girlfriend could not get her pelvic floor to calm down. And then after we graduated a couple years later, she got rhabdomyolysis. And then another girl could not get her pelvic floor to go up at all. She laughing, standing, coughing, running. Everything was just zero or one. And then later, before her and I had children, we ran a half marathon together and she peed herself the entire time. So I just feel like there were things underlying the surface at the pelvic floor that didn't pop up until later. And so that biofeedback machine might have actually been really cool, and which kind of led me down the rabbit hole of pelvic floor stuff. Also, in this time, I found out that I was really good at talking about awkward conversations and TMI. I have a whole bunch of friends that don't really know each other, and they were all asking me to take boudoir pictures for them or just like prep them for fun intimacy marriage things. Or I found out that some people were having pain with intimacy and they had waited until marriage and then now they're having pain with intimacy and it didn't seem like that big of a blessing. And I really wanted it to be. Also, after I had been an outpatient for a while, I started noticing that a lot of my people were getting better for low back pain, but the ones that were having the hardest time get better with low back pain also had abdominal surgeries like C-sections, hysterectomies, big appendectomies, and then they also had some pelvic floor dysfunction. So I was like, well, it makes sense to treat the back and it makes sense to treat the front, but why aren't we treating the stuff in the middle? And so that also kind of let me go down that road. So in the meantime, I got into this thinking I will have no issues. Like it's going to be so nice, and where I have a baby, I can just be super duper objective. And it turned because my mom was. She had 4 kids. She just like blinked an eye, and the babies were out of her. And I was like, well, that's what I'm going to do. So instead, I have had 3 children. One was an unplanned C-section. She was still breech when we got to the hospital, and so C-section for that, and that was terrible. And then the next baby I thought I was gonna have a C-section, so I didn't do anything to prep for it. And I had an unmedicated vaginal birth that was terrible. And then we were gonna not have any more babies. And then I had a surprise baby in June of 2020, which was super scary in 2020. And so I didn't like any of those babies, or any, I loved all the babies, but I didn't like any of the deliveries. So it really makes me know how every single rehab and every single birth was so different that I can bring a lot to the table of just expertise of rehabbing myself. Something that I wish someone would have told me 11 years ago whenever I started this, at that whenever you were treating for pelvic floor, you're in a room without windows. So I make sure to really enjoy my lunch. I make sure to go outside. I walk. I get the sun because otherwise, the windows that I have are covered up all the time. So I really wish that I would have someone would have told me that. Now I am teaching. I TA for Herman and Wallace. It's one of the main institutes for pelvic healthcare and how you become a PT. And if you want to specialize in pelvic floor physical therapy, they're one of the main ways you can like get that PRPC certification. And so that's why I train with them. Is I love getting a hold of a brand new pelvic floor physical therapist and talking them to like, what does this actually look like? Like so they're teaching you this, and then you on Monday, you're gonna have a pelvic floor patient in front of you. And what are you actually gonna do? Like, how are you gonna implement what this knowledge is teaching you to a person sitting in front of you? So that's why I put um, expert pelvic, expert pelvic floor physical therapy is because I really want to get into the mentorship uh, scope of things too. Because if I can treat really really good for pelvic floor, and then how cool would it be if everyone started treating really good pelvic floor, and then everyone's pelvic floor physical therapist is top notch. Because sometimes whenever people come to see me, they're like, "Well, we tried a few things." I'm like, well, that's okay, but did they do XYZ? And they're like, no. I'm like, well, let's try those things. So, my clinical ethos. So, to unpeel layers of the onion, to rid each patient of pelvic floor dysfunction. So, this person comes in to see me and they tell me all their things that's going on. They've got SIBO, they have flat feet, they had a couple of babies, they were in a car accident, hurt their rib. And so, taking all of that information and then turning it into why their pelvic floor is grumpy. So I find that if we can find ways to decrease the demand at the pelvic floor, so there's one less thing for it to do. So if someone's weightlifting and leaking, then what if we change the position of their feet so that, or what if we change the position of their chin so they load the tissue better and redistribute that weight off the middle of them so that way it will behave or be less grumpy or hurt less or leak less or have less pressure. So I assess everything and treat everything that crosstalk the pelvic floor. So that is so much stuff. We have the vagus nerve and in our cervical spine. We have all this stuff in our ribs that actually end in the pelvic floor. We've got the sacrum, obviously. We've got the direct pelvic floor muscles and bones, and then we have stuff all the way in our toes that actually crosstalk to the pelvic floor. I love honing in on the natural reflexes of the autonomic nervous system to allow that patient to return to normal function. So there's all of these reflexes that we have. Chewing is one, pooping is one, having the urge to pee and telling your brain and your bladder that they don't have to be Pavlov's dog best friends. Honing in on those reflexes and letting your body do those naturally makes my job really easy. So I also give people reasonable home exercise programs so they'll actually complete it and feel pride and not shame. So more than not, the people that come to see me because they're embarrassed. Who wants to be peeing and pooping themselves or have so much pain that you can't sit? Like you're in a meeting and you cannot be the one that's sitting. You have to be the weirdo that's always standing. That sucks. So they feel a lot of shame whenever they come to see me because they hurt in private places. And I want everyone to know that there is no reason to feel shame. Everyone poops. Everyone has a pelvis, men and women. And so in every single one of my YouTube videos that I make, I say, you are fearfully and wonderfully made. Um, we were thought our bodies are so magnificent that as you unpeel layers of the onion and then people just get better, it's just so beautiful at how intricate and detailed everything is. So I just want everyone to know how special they are. So the typical diagnoses that I treat a ton of urgency and frequency of urination or bowel. Like if someone gets the urge to poop and they're like, "Oh my gosh, I'm gonna poop my pants," and they only get like a second and then they're pooping their pants. I treat that and I fix that like within one visit. It's so lovely. I treat constipation. I mentioned earlier that I am specialized in Parkinson's. I've been doing that for over a decade. I do pre and postpartum care. I treat multiple UTIs for young people and for, I mean, all spectrums from 9-year-olds to 90-year-olds. Pelvic pain, inability to sit, tailbone fractures, like whenever there's an ice storm, I get to see a lot of them. Stress urinary incontinence, so whenever they're sneezing, whenever they're lifting, any heaviness, like so someone will be like, I was in the shower and I felt something weird in my vagina, and I just told them that's where the organs are, like, but they're just a little bit lower than they used to be, and then I help them relieve some pressures. That way, that will go back up. Low back pain, smearing in underwear, like they're not leaking bowels, but every time that they wipe, then like they have issues. And so I talk to them about that, and I can usually fix that in one visit too. And I treat a lot of PCOS and endometriosis pain. So, which is complicated. So whenever someone comes to see me, actually let me pause and see if there's any questions already before I get into what to expect in an evaluation. Okay, good. Thank you. So when someone comes to see me, the first thing they do is they tell me what's going on and why they're here. Like no one wants to be in my room, but if they were confident enough to tell a doctor to actually go to see a physical therapist for this private thing, then I want to know why they're here and why they're going to keep showing up. So I do a general orthopedic evaluation. I have them stand up. I have them bend over. I want to see what happens whenever they pick up something heavy, when they pick up something light. I have them lay on their back on a treatment table. I start at their toes. I see how much their toe mobility their toes have, how much ankle mobility their talocrural joint have. I do their hips, hamstrings, external rotation, internal rotation, and then I go ahead and put my hands on their rib cage. I want to see what happens when they take a big breath in. Do they take a big breath in and only use their at the front of the top of the chain? I'm really good at that. Do they take it all into their ribs and their lungs? Do they take it all into their belly? And then I just give them some tips on that right away. Then I also look at their tummy and see if they have any abdominal tension or scars. So scars are actually really huge. Another example is an appendectomy can is like the number one cause of a tilted uterus because that scar tissue has to cut on one of the uterosacral ligaments. So then the baby is shifted, like just kind of interesting. So I treat a lot of scar tissue at that time. Then I tell the patient that we're going to do an internal evaluation. I preface this with no is always a full sentence. Um, com- whenever whenever someone says that they want to participate in this, it should be constant. Like it should be a constant yes. It should be super duper willing and enthusiastic. So before we do, before I start consent, then I have a little model. I tell them about what to expect with this little model. It's paper. I used to have a very realistic vaginal model, and then no one would look at it. Like it was like so realistic. People would be like, uh huh. And so then I had to stop using that. I just started using a little paper model, and I use this one, and I give excessive education about anatomy. And whenever someone gets it, like, oh, this is just like a neck, or this is just like a rotator cuff, but it's in a really private space, and this lady seems to know what she's doing, then it just goes really well. But I really, really want their central nervous system to trust my central nervous system. And so if I get a vibe that this is not going to go well, then I don't do it. I save it for a different session. I always start off the conversation like, hey, I have time for internal exam. Would you like that today? And the answer can be no. And the answer is no for some people all the time, forever. But it really stinks if I don't offer it and then they come into the session and that's the one time they like prep themselves like I'm gonna do it, I'm gonna do it, and then I don't offer it. Like darn, because no one else is gonna look at these muscles like a pelvic floor physical therapist. So the goal for the patient that I have for them, I want them to be comfortable. I want them to trust me. I want them to know that I know what I'm doing, know that I have a plan, that I'm not going to gaslight them, that I'm going to listen, I'm going to understand, and I'm going to be real with them, and I'm not going to pressure them. So that is the prep work for an internal evaluation. If I get a vibe at any point in time that this is not going to happen, then we just stop. So then I tell them that there's three layers. So there's an outermost layer. It forms the clitoris and the penile tissue, erectile tissue, for both of those anatomy structures. And it starts on your sits bones. The second layer is very hormonal and automatic. It's very sphincteric. And we're usually honing in a sneaky way on that second layer. Um, but the but we'll usually cross that bridge on a different day because I can't treat that right away. So I do males and females initial evaluations separately, differently, because males' superficial layer can actually reach on the outside. I spend a lot more time at the ilioinguinal canal and just see how much better they can get with penile and testicular pain specifically, just with treating on the outside of their body on the first day. I usually find out that a lot of them have an old hernia or an old surgery, like abdominal surgery at some point in time, and they can get better so much just with looking at like their thoracic spine or their abdominal cavity. Common findings that I find is that having correct posture increases the activation of those pelvic floor muscles. So in whenever you decide I want to be a pelvic floor physical therapist, you go to pelvic floor 101 and they're like, and you gently place your finger on those muscles and then you say contract, do a kegel. And a lot of people are like, I don't know what that is. But I find that if I hold my finger there and I have them do other things, I want to see what it looks like whenever you squeeze your shoulder blades together. What does it feel like whenever you crunch down? What happens whenever you put your toes in the ground or put your heels in the mat? That their pelvic floor will just activate. And that's what I want them to learn is that their pelvic floor, we don't have a good understanding of it. But if a finger's there, then it kind of makes your brain go, this is weird. Doo, 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 doo. And then they can feel what they're actually supposed to feel. So that people actually have good strength, but they have poor speed and quickness of their pelvic floor. So a lot of people, they're like, I'm going to practice my pelvic floor contractions. I'm going to practice my Kegels before I see this chick. And then they've been practicing like hold, hold. And eventually they're like, I can't tell if I'm holding it. And they stop. because they don't have the speed that it takes to catch the thing, to stop the sneeze. And so if I work on speed, they usually get better pretty quickly. Most people are holding their breath, and most people are exhaling on the wrong part of the lift. And so I'll go over that with my case studies. Because it is huge. And I have 4 techs. I see a lot of them here in the raise your hand if you work at PT of Wimberley and PT of St. Marcus. So these are a good group of crew right here, but they are the ones that remind my patients to always be um, not holding their breath. So this is a handout that I've made, and I specifically start to unpeel layers of the onion. And the reason why I'm showing you all of this is that if someone comes to see me and they are not going to be doing an internal exam, I can just see in their eyes they are scared, they are uncomfortable, they don't really want to be here, then I will start at their thoracic spine, because all of this thoracic spine then coordinates and maybe will calm down their central nervous system to work on their large intestine, to work on their kidney, to work on their ureter, their bladder, their uterus, their prostate gland. Because all of these things refer pain to the spot that they don't want to have. Like T8 through L1 is way up here, like where your bra strap is, and it refers pain to the sacrum, the testicles, the lower abdomen. Like people tell me they have pressure in their tummy, like picture period pain, and you're like, gosh, it hurts. Well, if we can do some stuff way up here, it may alleviate some of that pain. And that is pretty neat. So, other things you do, there's not going to be a pop quiz on this, but what other things on the outside of the body can I give them exercises to do out in the gym, at home, specifically to unpeel those layers so that way they can have less symptoms? I start at the abdomen because it's easier to reach. And then I go through all of these things here. The myofascia, did they have a hernia? Is there any scar tissue? Is there any constipation? Can I just rub your belly? I love to belly rub. Like I give about 10 belly rubs every single day. Then what's happening at their thoracic spine? Do they have super duper poor posture? Because look at what your posture is doing when you're squished over. You're literally squishing the pee and the organs down. And if the pelvic floor isn't strong enough, then either you're going to have leaking, you're going to have heaviness, or you're going to have all those muscles like really, really tight and fisted down there, being like, no. So, can we make everything soft and supple? I look at hips and feet because they matter for that space right there. Then, this next page is all the things that are a little mind boggling, but they're all the things directly at the pelvic floor. So, whenever I get to treat someone for physical therapy, for pelvic floor physical therapy, everyone treats differently. And that's why if someone does not get better with my pelvic floor physical therapy, I'm like, hey, this is how I specialize. This is how I treat. But there are other PTs out there that do it completely differently. And just because we don't vibe or you're orthopedically um, not getting better with how I'm doing this, it doesn't mean that you're broken. But I typically get 15, 20 minutes, maybe 30 minutes with someone, and then I hone in on all of these things on the inside of their body too, especially pelvic obliquity, which is on the outside of your body. But then what can we do to decrease and make everything less grumpy? And so I hone in on those things, and then they go out in the gym and they work on all of the hip and the thoracic and the tummy stretching or the strengthening out with my text with all the people that you just saw their hands raised. So I have 6 case studies because you're like, what would this actually even look like? So I have them in no particular order, but I'll have a 6-year-old male after his prostate's been removed for cancer. He only leaks urine when he leg presses over 400 pounds. So not 200, not 300, but as soon as he hits like 360 and up, then he starts to leak. And especially if he drinks his coffee on the way to the gym. So for him, one of the first things was like, maybe drink your coffee after the gym. Like pour your cup of coffee and then put it in your cup holder and in one of those Yeti things. Keep it good and hot. So whenever after you're done exercising, you come in and you reward yourself with that first sip of coffee. That alone made him 10 times better. Like he's like, oh, I can already make it to 300. Then we worked on pressure management. I have a leg press machine out there. So then I had him go out and do pressure management. Let's see what it looks like whenever you're lifting 200 pounds. I saw him and he looked fine. He did 300 and all of a sudden his face started getting all Valsalva. his pelvic floor was not strong enough for that Valsalva technique. So Valsalva is a good lifting technique. You literally are just like shaking up a Coke can and you're not opening up the top. So you're really stabilizing everything. But if you're a gentleman and you don't have a prostate anymore, then you don't have that sphincteric muscle underneath your bladder. Women don't have that, which is why women have more issues than men concerning leaking, is because they don't have a sphincteric walnut shaped muscle that's like holding their bladder up better. So I had him back off the weight until he did not leak and then slowly progress up in the weight. Took him 4 sessions, like that over 6 weeks, like maybe four. I mean, really, not even 2 months of meeting me. He high fived me. He came in one day. He's like, I don't even need you anymore. Oh, I love that. I love that. So then next, I have a 25-year-old that's had a lifetime of painful periods. She's been having her period since she was 10. So 15 years of pain that are steadily getting worse. I helped her get a diagnosis of an endometriosis. She started having endometrial surgeries where they go in and they actually like start to extract endometrial tissue, which is uterine tissue that when the baby was being made in utero, just kind of just like went everywhere. So whenever she was having her period or anyone with endo, that their uterus is contracting and getting grumpy, but then everything else that has uterus tissue is getting grumpy too. So in the bowels, it can be up in the lungs. They're actually saying that some people have uterine tissue in their brain, so like it just like headaches and migraines, and it's just crazy. So first, she has to get a doctor to help her. And then I just unpacked layers of the onion for orthopedic and her posture. She was always hurting, so her shoulders were always in this position. We talked about pain management, heat, and ice, and I worked on vagus stimulation, which is all this stuff like woos on the front of your in the front of your neck, and what can you do at your tummy. We worked about diet and exercise. So PCOS, along with a lot of thyroid conditions, really benefits from heavy weights to make your glucose do the things it was supposed to do. And so it took her years of sessions. I'm still seeing her. She's one of my first patients in 2019. And then I have several people that fall into this category that I just see them. I see them once a month. I kind of have their plan of care pretty open. It's a little hard concerning documentation and insurance reimbursement, but I give care how I can. So if I don't get paid for one of her sessions, like she still gets better, and I'm okay with that. So the next is a 60-year-old female with Parkinson's diagnosis, just got diagnosed, but she's also having urinary urgency, frequency, and constipation. Constipation is one of the first symptoms of Parkinson's. So I already start to provide education on what Parkinson's is because she's out there reading all of this stuff. And then I get to give her the same information, but from a PT perspective. And knowing that when she feels lightheaded upon standing, that's part of her autonomic system being affected by the Parkinson's. And what can we do to do that? Can we combat it with a little more salt in our diet so that way you don't get low blood pressure? I'm giving her leg and ankle stretches so that way she can address her urinary urgency and frequency up and down the chain because the nervous system goes all the way down to our big toes. Tell her how to do colon massages to address that constipation. That way it's one less thing pressing on the bladder. So if your bowels are full of poop and they're just not moving because you have Parkinson's or anything else, and then it has nowhere else to go. And then it presses on your bladder, and then your bladder's like, get off me. But your bladder only has one sentence, and it says, I need to pee. So every time that gas is up against it, every time that there's bloating up against it, every time that there's constipation up against it, then your bladder says, I need to empty. I need to empty. So then you have urgency and frequency, but it's not that anything's wrong with your bladder, it's that something else is touching it. So I gave her the LSVT, which is 16 sessions, very intense, big movements. It's lovely. And then I've been seeing her for years. The urinary urgency and frequency went away pretty well. She has to do everything all day long for the constipation, but it's really lovely. So then we have a 36-year-old first responder male with urgency and frequency that does not allow him to sleep. It affects his job at crime scenes. He can't hold it as long as he needs to at some of these crime scenes or some of these traffic accidents. So on the first day, we talked about diet because he's tired. Like, so he's like working 36 on and 12 off or wherever. But so he's drinking nothing but caffeinated drinks. And then whenever he gets a call, he quits drinking anything, and then he's eating whatever he can, which is also causing food triggers and bladder irritants of caffeine and alcohol. So finally, he gets off of work and he wants to have a drink before he goes to bed, but it quickly doesn't allow him to sleep well either. So he got rid of the caffeine and alcohol pretty quickly, already started sleeping better. Turns out he had a hernia 20 years ago. And so that scar is right on that ilioinguinal canal, which is the base, is the same tissue that is the base of the scrotum and the base of the testicles, which is also pulling at that urethra. So we worked on the hernia scar just on the outside of his body. And that's something he can do in the shower. No one wants you to like touch the spot on you, but in the shower, you're already going to have to be soapy. And so we also managed constipation, and he had a tailbone fracture from years ago. And so we had to work on getting his pelvis in the right position so his sacrum could calm down, so his tailbone could get pulled in the right position. So that way those pelvic floor muscles would just calm down. Took 8 sessions over the course of like 3 months. But he did everything I asked and he got better really pretty quickly for the amount of complications that he had. So then the last two is I had a transgender female. She declined all internal assessments, but she requested a female for low back pain when running. She had been a runner her whole life, but it was really getting bad. So right in her SI, so that way she could not run. So right away, it's kind of complicated because then we're talking about hormones. But she had been adding decades of hormones into her body to make her ligamentously lax. So the testosterone was no longer holding those ligaments in place and holding those bones in place. So her SI really was hurting. The hormones were helping her feel more like herself, but she needed an SI belt to hold everything in place. We worked on running form, we worked on footwear, we worked on getting her more internal rotation and strengthening in that position, so that way her running form was just better. Because if your feet are hitting the ground in a wonky way, then it changes your knees, it changes your hips, and then your SI has to take the brunt of that. It took her 10 sessions, but then she returned to running half marathons again, and she was 70 years old. Like, it's amazing. So then now this is one of my first patients, and I didn't really understand what to do on the outside of someone's body at this time. So, 25-year-old mother, teacher, 3 children, and she leaks whenever she chases her kids, and her back always hurts. Like, but she's just used to it because it's hurt since the first baby, who's now 6. So she had some SI dysfunction, so we had to move her pelvis back into that position. My boss came over, and I was like, I've been fixing things inside, like trying to make her strong on the inside of her body for a while. It's not really working. And he's like, well, let's look at what's going on with the pelvis. And he worked on the pelvis, and then within 1 week, she was no longer leaking. Like, so neat. So she did have some scar tissue, but that scar tissue, once I relieved that scar tissue, it allowed those bones to go in the right position. So that way the pelvic floor could just activate and catch the urine whenever she was running, like pounding and laughing and just not having any more scar tissue for the C-section and the vaginal tears allowed everything to be how it was supposed to be. She also was one of those people that had poor speed of her pelvic floor. So it was once she found out that she's not supposed to hold like forever, but really like, oh, like lift. And the way that the word that I say is pucker. So pucker, 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 real fast. Like you're snapping your fingers. Everyone do it 5 times. 2, pucker, 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 3, 4, 5. But doing that, lifting your anus, lifting your testicles, you'll feel that in your lower abdomen. You'll feel everything kind of stack up on top of each other. And then she was able to use all of her pelvic floor muscles whenever she was running. She also found out that she was a toe runner, but she actually used her heels more to turn on her pelvic floor. So I had to tell her she had been a sprinter in high school. So she ran on her toes all the time. But what happens if she could start hitting the ground with her heel and pushing off with her toe? And then she also, again, no longer had issues. And it only took 4 sessions, 25 years old though. So those are my 6 case studies. And so that's how I got to be a pelvic floor physical therapist. It was kind of by fate. And then now I know that I'm really good at it. And so I have online classes and a pelvic PT mentorship program. It's Stacey Murphy Pelvic PT Public Health Physical Therapy at Teachable. I've got classes that are $13. I mean, like they're a quick little blip. That's the one that like my mom bought. She was like, I just want to see. And so she wanted to make sure that it all looked good. I've got some that are $50. I used to have them be 100. I just went down because I just want all this information to be accessible. And then I have a mentorship program for new public floor physical therapists that are $50 a month. So I'm at PT of St. Marcus and PT of Wimberley. That's my email if you ever want to send me a resume. I'm usually I got somebody getting into PT school, so I'm always hiring, and so it's nice working with the community and making friends. So, is there any other questions? Thank you. God bless. Okay, so that was everything. I am so happy to be here. You take care. Thank you. You are fearfully and wonderfully made.